And then it is my pleasure to invite the second young physician, Dr. Madhushankar Ratnayaka. He's a senior registrar in respiratory medicine at the NHSL Central Chest Clinic. My great pleasure to invite Dr. Madhushankar Ratnayaka, a senior registrar in respiratory medicine at the NHSL. And Madhushankar is going to talk about, is there a light beyond lights criteria? Evaluation of complex pleural effusions. Right, Madhushankar, over to you. Thank you.
Thank you very much, dear Arosha sir, for that kind introduction. At the outset, I would like to take this opportunity to thank Ceylon College of Physicians to giving me the wonderful opportunity to address this elite audience. So during the next 30 minutes, I would take you through a journey on evaluation of complex pleural effusion. Is there a light beyond the lights criteria? So let's find out. Outline of my talk will include transudative versus exudative effusions and a stepwise approach to evaluation of pleural effusion, interpretation of a pleural fluid report, radiology, and the role of interventional pulmonologists in case of pleural effusions and few case scenarios. First, a transudate is formed due to leakage of fluid across an intact capillary barrier. It may be due to increased hydrostatic pressure or decreased osmotic pressure. It indicates that the pleural membranes are healthy. However, exudates are caused by leakage of fluid or protein due to altered capillary barrier with increased permeability. The etiology of transudates are multiple, which spans starting from congestive cardiac failure up to iatrogenic causes. The etiology of exudates are also a myriad, ranging from infectious causes such as pyogenic infections, tuberculosis, fungal infections, ranging to neoplastic conditions and collagen vascular disease, all up to radiation, hemothorax, and chylothorax. So a stepwise approach should be adhered whenever you are evaluating a pleural effusion. To start with, after the physical examination, you should do a chest radiograph, a diagnostic thoracocentesis, contrast CT, and ultimately a medical thoracoscopy if needed. Let's talk a few words about thoracocentesis. It should essentially be done under ultrasound guidance, and the complications are very rare, which include pneumothorax and hemothorax. However, following an uncomplicated thoracocentesis, post-procedure chest X-ray are not recommended. This is a schematic diagram showing the technique of obtaining a pleural fluid sample under ultrasound guidance. A stepwise approach should be always followed for the interpretation of pleural fluid aspirate report. It starts from the inspection of gross appearance of pleural fluid, followed by, in the following order, of protein, glucose, lactate dehydrogenase, white cell count, cytology, and so on and so forth. First of all, what is a normal pleural fluid parameter? The appearance should be clear to straw color, and the pH should be 7.6 to 7.64. The protein concentration should be less than 2% that of plasma protein. The white cell count should be less than 1000 cubic millimeters, with macrophages being the predominant cell. The glucose in pleural fluid should be similar to that of plasma, while pleural LDH should be less than 50% of that of plasma. First, the gross appearance order should be inspected, where if it is putrid, it supports a pyogenic, especially anaerobic infection, while if it smells like urine, it's like a urinothorax. Color-wise, if you found your aspirate is grossly frank pus, it supports a diagnosis of empyema, while if it is blood-stained, you need to differentiate between a hemothorax and a traumatic tap. For that, you have to use the pleural fluid hematocrit to blood hematocrit ratio. If this ratio is more than 50%, that supports a diagnosis of hemothorax, while if it is 1 to 50%, it suggests other etiologies such as malignancy, pulmonary embolism, and traumatic tap. If the pleural fluid is turbid, milky, or bloody, always you have to centrifuge the sample and examine the supernatant. If the turbidity disappears following centrifugation, the turbidity is possibly due to cells or debris. However, if the turbidity persists following centrifugation, it may be due to a chylothorax or a pseudocylothorax. Differentiation of chylothorax from pseudochylothorax based on pleural fluid triglyceride and cholesterol concentrations. If the pleural fluid triglyceride is more than 110 milligram per deciliter, it is more supportive of chylothorax, while the pleural fluid cholesterol level is more than 200 milligrams per deciliter, it supports a diagnosis of pseudochylothorax. Pleural fluid protein, if it is less than 2.5 grams per deciliter, it supports a diagnosis of transudate, while if it is more than 3.5, it supports a diagnosis of exudate. However, if the value falls between 2.5 to 3.5, you have to apply the Light's criteria. I will go get back to Light's criteria in the following slides. You have to know that if the pleural fluid protein is very low, less than 0.5 gram per deciliter, you have to suspect a urinothorax, effusion secondary to peritoneal dialysis, leakage of CSF, or misplaced central lines. Pleural fluid LDH originates from filtration of serum. It serves as an indicator of vascular permeability. Very high levels of pleural fluid LDH of more than 1000 indicates that the patient is having either empyema, malignant or rheumatoid pleural effusions, and in rare cases, paragonimiasis also a possibility. Coming back to Light's criteria, an exudative effusion is defined as the pleural fluid protein to serum protein ratio greater than 0.5, or pleural fluid LDH to serum LDH greater than 0.6, or pleural fluid LDH greater than 2/3 of the upper limit of the serum LDH. It has a sensitivity of 98% and a specificity of 72%. However, the Light's criteria can misidentify a transudative effusion as exudate in 25% of cases, especially in patients with chronic kidney disease and congestive cardiac failure who were treated with diuretics. In such scenarios, you have to use the serum protein to pleural protein gradient of more than 3.1 grams per deciliter, or serum albumin to pleural albumin gradient of more than 1.2 gram per deciliter, which supports a diagnosis of transudate. The pleural fluid pro-BNP level of more than 1,500 picograms per milliliter has been seen in transudative effusions due to cardiac origin. However, it's not widely available. Pleural fluid cholesterol of more than 60 milligrams per deciliter supports an exudative effusion with a 92% accuracy. However, pleural fluid cholesterol of more than 60 in combination with pleural fluid LDH more than 200 will offer equal sensitivity as Light's criteria with 99% sensitivity and a 98% specificity. Pleural fluid glucose. When the pleural fluid glucose is low, it indicates that either the pleural membranes are thickened or there is increased metabolic activity in the pleural fluid. If the pleural fluid glucose is less than 60 milligrams per deciliter, there are 7 possibilities, out of which parapneumonic, malignant, TB, and rheumatoid effusions are the majority. The pleural fluid white cell count should always be sent in a tube with an anticoagulant when collecting samples to prevent clumping of the cells. The total WBC count has a limited value. And if the WBC count is more than 1000, it is suggestive of an exudative effusion. However, with the differential count only, you can come to an idea of the origin of the effusion. If it is polymorph predominant effusion, it can be due to pneumonia, pulmonary infarct following pulmonary embolism, pancreatitis, intra-abdominal abscess. However, keep in mind that in early TB and TB empyema, there may be polymorphic predominance. The lymphocytic predominance in pleural fluid can be seen with tuberculous, uremic, and collagen vascular disease as well as malignant effusions. Pleural fluid eosinophilia is defined by eosinophilia of more than 10% by differential count, and common causes are pneumothorax and hemothorax. However, unusual causes should be sorted, such as asbestosis, drug reactions, or paragonimiasis. Mesothelial cells are a usual constituent of pleural fluid. However, it is absent in tuberculosis. The pleural fluid cytology offers a chance of a positive malignant cytology with multiple samples rather than obtaining a single sample. If you use 3 consecutive samples, the chance of catching a malignant cell in the cytology would increase up to 90%. For a higher yield, apart from sending the cytology smears, one have to make cell blocks as well. With related to pleural fluid culture should be done for bacteria, mycobacteria, and fungi. And the culture should be done from the sediment of the pleural fluid. And for a higher yield, you can incorporate this pleural fluid in blood culture bottles to increase the accuracy from 38% to 59%. The pleural fluid pH, if it is less than 7.2, it indicates 9 differential conditions, out of which complicated parapneumonic, rheumatoid, tuberculous, and malignant effusions predominate. If the pleural fluid pH is less than 7.2, it warrants an IC tube insertion. However, pleural fluid measurement is a cumbersome procedure, and it should be collected anaerobically in a heparinized syringe and placed on ice. If the specimen processing time is delayed, it can lead to false elevation of the pH due to loss of carbon dioxide. However, pleural fluid glucose goes in hand with pleural fluid pH. So if there is inability to do the pleural fluid pH, pleural fluid glucose can be guided for your further management. Pleural fluid amylase is raised in esophageal perforation, pancreatic, or malignancies. In esophageal rupture or malignancy, the salivary type amylase would be raised, while in pancreatic diseases, pancreatic isotype of amylase is raised. Adenosine deaminase or ADA is a product of activated lymphocytes. The levels are elevated in almost all patients with TB pleuritis, and if the level is less than 40, it can exclude TB in pleural effusion with a sensitivity and specificity of 90%. However, very high levels of ADA of more than 250 can be seen with empyema and lymphoma. In such scenarios, we have to use the pleural fluid LDH to pleural fluid ADA ratio. If this ratio is 16 or less, it supports a diagnosis of tuberculous pleuritis with a sensitivity and specificity of 93%, while if it is more than 16, it supports a parapneumonic complicated empyema. Molecular techniques, mainly including polymerase chain reaction, has been tried to use. However, it has a very low sensitivity, although the specificity is high. Therefore, TB gene expert is not recommended to use in pleural fluid. Radiology in pleural effusion, including the chest radiograph, ultrasound, and the CT chest. The chest radiograph in the upright position, if the fluid volume is less than 75 milliliters, it can occupy the lung without making any radiological changes. However, if it is more than 75 milliliters, it will start to obliterate the costophrenic angle. And lateral decubitus X-rays will demonstrate even 5 ml of effusion. This is a chest X-ray showing the right obliteration of right costophrenic angle. And then what is loculated pleural effusion? It is associated with conditions of intense pleural inflammation, such as parapneumonic effusion or tuberculosis. It is usually D-shaped with the base of the D sitting against the chest wall and the smooth convexity towards the lung hilum. So this is a chest radiograph showing the characteristic D-shaped parapneumonic loculated effusion. Then ultrasound scan of the pleural effusion is a quick bedside test. It lacks ionizing radiation and it's of low cost. It offers real-time visualization during the thoracocentesis. Also, it can identify coexisting lung pathology such as consolidations, pleural thickening. However, its operator variability. So for the first figure in your left of the screen shows a yellow color arrow where the atelectatic lung is seen as known as the classical fishtail sign. In the diagram shown in the right upper part of your screen shows multiple echogenic particles and fibrin strands in an organizing pleural effusion. If you tap this sort of pleural effusion, there is higher amount of granulation tissue, which can end up ultimately in thorax. Then in the lower down in the screen, you can see multiple loculations with pleural effusion. And if you do not do the thoracocentesis with ultrasound guidance, you may not have a chance to aspirate this sort of a effusion. So these scenarios emphasize the importance of ultrasound guidance during thoracocentesis. Next, come to the determination of the size of pleural effusion. Multiple formulas are there. The Bellick and Goker formula are the commonly used formulas. With the Bellick formula, the patient is kept in the supine position and breath held in end expiration, and maximum distance between the visceral and parietal pleura are measured and multiplied by 20. In the Goker formula, the patient is kept in the erect position at end expiration, and maximum distance between costophrenic angle at the far field of the lung base is measured, and it is multiplied by 90. The contrast CT chest offers best capability to evaluate pleural pathologies where unaerated lung will be enhanced and the pleural fluid will not be enhancing. It is important to distinguish a lung abscess which is sitting on the base of the pleura from an empyema. So, in case of an empyema, the cavity wall has a uniform thickness, both internally and externally, as shown in the diagram, and the adjacent lung is compressed, and the angle of contact with the chest wall is obtuse. However, in case of an abscess, the chest abscess wall is very irregular, and the adjacent lung is normal, and it forms an acute angle with the chest wall. In empyema, the shape is lenticular and demonstrates the characteristic split pleura sign, which is absent in lung abscess. What is the role of interventional pulmonology? Abraham needle biopsy, fiber optic bronchoscopy, medical thoracoscopy. So, Abraham needle biopsy is an outdated procedure and largely replaced by medical thoracoscopy during current days. It is used to diagnose malignant or TB pleural effusions. In case of malignant pleural effusion, due to the inhomogeneity of involvement of the pleura, it has a lower sensitivity. However, homogeneously involved pleural involvement diseases such as tubercular pleuritis, the Abraham needle biopsy offers a higher sensitivity. Complications include pneumothorax, bleeding, and accidental puncture of abdominal viscera. Bronchoscopy is not routinely done in all patients with pleural effusion. However, if the CT shows any parenchymal changes or endobronchial obstructions, there is a place for bronchoscopy. However, one should keep in mind that with large effusions, the bronchus can be externally compressed and impair the bronchoscopic visualization. Medical thoracoscopy. It's an aseptic procedure. The main indication would be an effusion which remains unclear following the diagnostic thoracocentesis as well as CCD chest. The advantages of medical thoracoscopy include it can perform biopsies under direct vision as well as it offers a chance to do the chemical pleurodesis. The medical thoracoscopy are done by the pulmonologist under conscious sedation with midazolam, and the video-assisted thoracoscopic surgery is done by the thoracic surgeons with one lung ventilation under general anesthesia, which is more invasive. So, medical thoracoscopy at NHSL Respiratory Investigation Unit in 2022, we did 15 thoracoscopies, out of which commonest indication was lymphocytic exudative effusion with a negative adenosine deaminase level. And there were 7 malignant cases, while there were 8 benign cases. This is a picture showing our team doing medical thoracoscopy at NHSL Respiratory Investigation Unit. Then I will go on to discuss few case scenarios. My first case is a 67-year-old male with ischemic heart disease, diabetes, and hypertension, complaining of orthopnea, paroxysmal nocturnal dyspnea. Examination revealed raised JVP, gallop rhythm, and he was managed as a congestive cardiac failure exacerbation and given IV furosemide. Chest X-ray shows there is a right side pleural effusion, and pleural fluid report shows that pleural fluid protein is 3.8. That is more than 3.5. So it's like an exudate. However, on clinical background, one can argue that this cannot be an exudative effusion. So in such sort of patients, you have to apply the Light's criteria first. In this patient, Light's criteria show that it is a marginal exudate. However, if you do apply the serum protein to pleural protein gradient, it is more than 3.1. So it's a transudative effusion. Congestive cardiac failure related effusions are largely bilateral and right more than left. There is, in addition to the effusion, there are interstitial and alveolar edema with ground glass opacities as well as cardiomegaly. Thoracocentesis is not generally considered in patients with congestive cardiac failure. However, in certain scenarios, such as unilateral effusion, bilateral disproportionate effusions, or in febrile patients, we tend to perform diagnostic thoracocentesis. The effusion is generally transudative unless the patient is treated with diuretics, where the patient can have an exudative effusion. The management includes afterload reduction with diuretics, therapeutic pleural tap in severely breathless cases, and pleurodesis and indwelling pleural catheter in case of refractory effusion. Case number 2, a 35-year-old male heavy alcohol consumer with recurrent hospital admissions and diabetes, presenting with fever, difficulty in breathing, and left side epigastric pain. And in the chest X-ray, there is a left side pleural effusion. The pleural fluid report color is black, and it is a exudative effusion, neutrophil predominance, and amylase is very high. So a black colored pleural effusion. The possibilities are empyema, malignant melanoma, or hemorrhage following pancreatic pseudocyst rupture. This patient had CCT and it revealed pancreatic pseudocyst. So chronic pancreatitis with effusions is an interesting entity. It is most often associated with pseudocyst formation. The mechanism would be a sinus tract will form and extend from the pseudocyst into the mediastinum. Then ultimately they rupture into the pleural surface, closing the pleural effusion. The effusions are usually massive, and it is usually left-sided, and markedly elevated amylase level of more than 1000 is supportive of diagnosis. Management is basically conservative, including nil-oral NG suction, atropine use, and repeated therapeutic thoracocentesis. However, 60% cases will fail the conservative management and end up with surgery, pseudocyst drainage, or VATS decortication. Case number 3 is a 45-year-old end-stage renal failure patient with hemodialysis, presenting with fever, cough, and shortness of breath with right side massive pleural effusion. Due to the severe breathlessness, an IC tube was inserted, and on day 3 of illness, due to the symptomatic improvement, IC tube was removed. Following removal in the chest X-ray B, you can see that the lung has not expanded properly. So the pleural fluid report shows that it is a exudative pleural effusion. So this brings to a discussion about non-expandable lung. Non-expandable lung means inability to achieve a position of visceral and parietal pleural. Mechanism can be due to visceral pleural pathology or extrapleural pathology such as endobronchial obstruction. Visceral pleural pathologies include lung entrapment and the trapped lung. So what is the difference between lung entrapment and the trapped lung? It's during lung entrapment, it occurs due to an active disease of the pleura, such as malignancy, infection, or inflammation, causing an exudative effusion with increased capillary leakings. And dyspnea usually improves following thoracocentesis. Treatment of the underlying disease is usually adequate in this sort of effusions, and it sometimes needs indwelling pleural catheters or therapeutic thoracocentesis. In case of trapped lung, it is usually due to a remote inflammatory insult which has occurred in past, such as pneumonia or uremia. It's a transudative effusion formed due to the increased negativity of the intrapleural pressure due to a fibrous peel. As you can see in the diagram, there are multiple strands formed in the pleura, causing interference and increase in negativity of the intrapleural pressure. So in such patients, dyspnea worsens following thoracocentesis. If the patient is asymptomatic, you can observe and proceed. However, if the patient is symptomatic, they need VATS decortication. In case of pleural fluid, pleural effusion in CKD, majority are transudative, and they are due to fluid overload, congestive cardiac failure, or hypoproteinemia, which is usually bilateral. In case of exudative effusions, the main possibilities are tuberculosis, uremia, and parapneumonic effusion. Uremic effusions are mainly due to toxins, and they can occur at any age, irrespective of the stage of the chronic kidney disease. And they can worse following dialysis, and it is independent of dialysis frequency and duration. Pleural biopsy will show chronic fibrinous pleuritis, and 75% of cases will improve following initiation of dialysis. However, 25% may propagate into a chronic pleural effusion with pleural thickening, which may require decortication. Case number 4 is a 48-year-old male with cirrhosis presenting with fever, shortness of breath, and cough. There is a right pleural effusion. Pleural fluid color is turbid, and it is a exudative pleural effusion with neutrophil predominance. Gram stain is awaited. In a patient with cirrhosis with ascites having a pleural effusion, one should ring a bell regarding hepatic hydrothorax. So, this is known as spontaneous bacterial pleuritis. Because if it is a pure and simple hepatic hydrothorax, the effusion would be a transudative effusion due to fluid transit from ascitic peritoneal cavity into the pleural cavity through the defects in the diaphragm. However, this hepatic hydrothorax has got secondary infected. In that case, we term this as spontaneous bacterial pleuritis. However, in this background, you always have to exclude a pneumonic process. The older term which was used was spontaneous bacterial empyema. The diagnosis of this, if the culture of the pleural fluid is positive, more than 250 neutrophils per microliter would be adequate. But if the pleural fluid culture is negative, pleural fluid neutrophil count of more than 500 will confirm the diagnosis. You have to keep in mind that nearly 40% of spontaneous bacterial pleuritis cases are not associated with coexisting spontaneous bacterial peritonitis. Management would include IV broad-spectrum antibiotics. Case number 5 is a 40-year-old female with diabetes presenting with fever, cough, and shortness of breath. There is a right side pleural effusion on the chest X-ray with no parenchymal lung changes or mediastinal adenopathy. Pleural fluid report color is purulent and it is a exudative effusion with neutrophil predominance, and ADA is high, more than 40. So whether it's a TB pleural effusion or a empyema, for that differentiation, you have to apply the pleural fluid LDH to ADA ratio. In this patient, it is less than 60. So it supports a diagnosis of TB empyema over a pyogenic empyema. Tubercular pleural effusion is the second most common form of extrapulmonary TB. It may be due to reactivation or primary infection of the pleura. A delayed type hypersensitivity reaction to mycobacteria is the commonest pathogenesis, although a rupture of a subpleural gonfocus is also another explanation. It's usually unilateral, moderate, and self-limiting in case of a simple tuberculous pleural effusion. So, what can happen to this pleural effusion? It can convert to TB empyema, pseudochylothorax, or can cause recurrent pleural effusion due to residual pleural thickening. In case of TB empyema, it is mainly neutrophilic, and purulent fluid will contain numerous amounts of mycobacteria, and you can have the higher chance of detecting AFB and TB culture in this sort of patients. However, with time, pleura thickens and get calcified, and it end up as a trap lung. So, a referral to the thoracic surgeon should be offered at that time for wax decortication once the pleural peel matures. So, my last case is a 74-year-old male who complained of shortness of breath and ankle edema of 2 months. Left-sided pleural effusion on chest radiography was there, and on physical examination, there is a hard, non-tender inguinal lymphadenopathy. Pleural fluid report, the color is turbid to milky, and pleural fluid protein shows it's a exudative effusion with lymphocytic predominance. The ADA is negative, cholesterol is less than 200 milligrams per deciliter, triglyceride is more than 110. That is 205. That means this is a chylothorax. So we proceeded with the ultrasound scan of the abdomen, and there is a query of a retroperitoneal mass where multiple differentials were entertained. And CCT abdomen pelvis confirmed that there is a retroperitoneal mass encasing aorta and other great vessels. However, there was no paraortic lymphadenopathy. Then the inguinal lymph node biopsy confirmed the diagnosis of chronic lymphocytic leukemia. However, the lymphoscintigram showing the lymphatic anatomy was normal, and there was no residual lymph leakage. So, coming back to turbid to milky pleural effusion, what are the differentials? They include chylothorax, pseudochylothorax, empyema, or leakage of tube feed. Chylothorax is defined as presence of pleural fluid triglyceride more than 110 milligram per deciliter, or presence of chylomicrons. The milky appearance is only seen in 22 to 44% of cases. They are usually unilateral and right-sided. How mainly they are asymptomatic because this chyle does not cause pleural irritation, and it has this bacteriostatic activity which prevents organisms from secondarily infecting the pleural fluid. Mechanisms of chylothorax can be due to compressive obstruction, direct involvement of the bile ducts, and
Dr. Madhushankar, sorry to disturb you. We are about 29 minutes. We are gone. Can we conclude so that we can have one question, please? Thank you.
Yes, sir. Yes, sir. The diagnosis is mainly clinically, followed up by CT chest and lymphangiogram. Management includes pleural fluid drainage and high protein, low fat diet, and surgical procedures in case of refractory effusion. So in summary, the Light's criteria is important in categorizing pleural effusions, and not all pleural effusions can be sorted solely based on Light's criteria. Then serum to pleural fluid albumin or protein gradient should be kept in mind in handling congestive cardiac failure effusions. Then differentiation of bacterial from tuberculous empyema can be a challenge where you have to use the LDH to ADA ratio. The milky pleural fluid needs exclusion of chylothorax, and role of the medical thoracoscopy should never be forgotten when evaluating a complicated pleural effusion. And after extensive evaluation, 15% of effusions can have no etiology. So these are my references. And finally, I would like to thank my primary trainer, Dr. Amita Fernando, Senior Consultant Chest Physician, NHSL, my second trainer, Dr. Bandhu Gunasena, Senior Consultant Chest Physician, NHRD Valisara, Ceylon College of Physicians, my colleagues, and all my patients. Thank you.
That's okay. In the absence of any questions, thank you very much, Dr. Madhushankar. Shall we have the certificate on screen, please? Thank you very much.
Thank you very
Okay.
much, sir.
Thank you so much for that excellent presentation.